great regional and international rehabilitation leader, neuro-rehabilitation leader. He has organized many neuro-rehabilitation conferences, and currently he is the chairman of Surya Neuro Center in Mumbai, and his area of interest is stroke and neuro-rehabilitation. And here in this afternoon, he will be talking on rehabilitation 2030 initiative, holistic approach to managing neuro-disability with epilepsy. Dr. Nirmal Surya.
Thank you, Chairperson of Trustability. It is a great honor to me to present this. Epilepsy is like, heart to me, and I sleep in epilepsy, work in epilepsy, talk in epilepsy, and my wife will say that this man is only with epilepsy, nothing else. So that's something my passion, and I will just show you in some time that how I look at epilepsy in this. Ferry has already touched into this. This was a landmark paper which tells us about the burden of neurological disorder and global burden. And you know that these are the #1 problem in India, and not only India, all over the world. And these are the second largest cause of global death, which is about 16.8, and which is much more into the developing country. And we really need to look at this. And just the region in context to the burden of the global neurological disorder, more than 400 neurological disease burden is high all countries, and you can see this data: 1 in 3 suffering from disability, causes of the disability worldwide. Figures are showing that 40% increase, second leading cause, and of course NCDs these are from Europe last time. So there can be a difficulty in diagnosis sometimes, treatment. Some of the diseases are not treatable. We talk about the MS, some of the refractory epilepsy is very, very challenging, and breakthrough alone are not sufficient. That's the reason the WHO has taken a stand on May 22, and it was passed and adopted intersectoral global action plan on epilepsy and other neurological disorder. It is the first time ever that epilepsy has been given a great importance by none other than the WHO. So epilepsy and all the other neurological disorder is something, as you know, that in many of the developing countries, epilepsy is a stigma. People do not tell people about epilepsy. They can't get married, can't get child. So that is what is the global action plan is, which is a vision for the future, strategic framework, coordination, responsibility and mechanism, and monitoring and accountability. So this was World Health Assembly, and it is being adopted by more than 110 countries. India, of course, is one of them. So these are the strategic objective and action areas which has been divided into 5 points, and which are for the member states, secretariat, international and national partners. And prioritization and governance, diagnosis, treatment and care, promotion and prevention, research, innovation, and information system and public health approach to the epilepsy, which is what is very, very important. Now, why neuro-rehabilitation in epilepsy? Why we are talking of epilepsy in a congress in the neuro-rehab? If you look at very closely, and those who treat epilepsy, they know that it affects motor system, so they name patients with hemiplegia, ataxia, hypotonia. It affects the language and speech, learning skill, behavior, memory and cognition, swallowing, social, education, marriage, job, family burden, and psychosocial, psychological comorbidity. So it is a condition which is associated with cognitive, psychological, and social consequences. Cognitive problem in patients with epilepsy can be caused by many problems, many things. There may be lesion in the brain which causes. There can be recurrent prolonged seizure which can affect. And sometimes the adverse effect of many of these drugs like topiramate, levetiracetam can be a problem. So memory disturbance, impaired attention, difficulty in concentration, fatigue, which all can affect the impact on the daily life. And there can be memory disorder in up to the 20 to 50% in patients with epilepsy with various reasons, which I'm not going to talk now. So why need to worry? We need to worry because there is a drug available for epilepsy, but drug alone may reduce the epilepsy, but yet person is not productive because he may have one or two, if he is getting 10 seizure, reduced to 1 seizure a day or 1 seizure a week, yet he's not been able to go to the work, do his normal daily activity. So now time has come that we deal the epilepsy in total like any other neurological disorder such as stroke, Parkinson's disease and Alzheimer's disease. So why is different in epilepsy? It's a hidden devil, I say. The disability is hidden. People are not worried about the disability, they are worried about the seizure. In children, there are different problems. Adolescent going with epilepsy has different issues. Adult with epilepsy, more trouble. Elderly people, different issue, alone, dependent, and the spouse, caregiver, all are hidden. Mother with epilepsy, late onset versus early onset, chronic, and then of course illiterate rural dweller, overtly God-fearing, blaming epilepsy as a curse, accept disease and do nothing. Literate urban dweller but not so different needs, stigma and poor attitude, run from pillar to post with no solution. So every month change the doctor or change place, sometime go to the religious place, sometime go to the Baba for other thing. So that's what something is happening. Taboos and catastrophe of patients who are seizure-free post-op find difficulty to accept normalcy. Family expectation and new life is still clinging into the past. So that's another issue which we are facing. We are doing epilepsy surgery. Expectation of family is now he has become normal. But patient has epilepsy for 20 years, he is not able to cope, sudden exposure to the world. So these are some of the issues which are there. So the model which we have created, I as a trustee of Epilepsy Foundation, working with National Health Mission, Government of India for the last 13 years, and I'll show you what we have done. So epilepsy with neuro-disability, epilepsy without disability. With neuro-disability, you have physical disability, speech and swallowing, learning, cognitive, psychosocial. And then under the cognitive is memory, behavioral, ADHD, autism, LD, etc. So there may be factors which can affect the cognition in epilepsy, and some of them are listed out here, and we need to look at into the pathological factor which can be there. As I mentioned, anti-epileptic drugs, psychiatric comorbidity, seizure, and interictal epilepsy discharges, they all can affect. There is a great correlation between IQ and seizure frequency, and you can see that repeated seizures are associated with increased intellectual impairment, and a negative correlation between frequency of GTC and performance of neuropsychological has been clearly observed. Epilepsy and language are linked together as both are generated in the brain, of course we know, and their neuropsychological impairment, which is cognition and language, significant comorbidity of epilepsy and affect sometime in 82% of children with epilepsy. The brain activities in Broca's and Wernicke's are stronger, more concentrated, and that can again affect the speech. There are patients who get the arrested speech after the seizure, and they can have difficulty when they get repeated seizure. Possible explanation of atypical lateralization would be epilepsy caused damage in the brain, and perhaps the damage trigger the brain to either activate or already acquired language area in the left hemisphere, or construction new area to compensate for the lack of functional area in left hemisphere. Epilepsy can affect the social life in all the way. In children it is difficult. There are many parents don't allow their children to go out and play with other children. School teacher and school, one epileptic attack in the school and they send the children back. When you get better, then you come. So the education is affected. The social functioning can contribute to difficulty in developing relationship, remaining in employment, and thus participation of the family, community, culture all get affected. And these are some of the ones which can affect the life, the quality of life in the patient. So if you look at individual and interpersonal determination of social functioning in epilepsy, you can see that society and culture, environment, friends and peer group, partners and family, healthcare, occupation, education. And if you look at cognitive processing and affective processing, you can clearly see that structural variation, functional variation, epileptic activity, drugs, psychiatric comorbidity, and developing trajectories are the one which can determine what the patient social interaction would be in the family, in the society. There are neuropsychological implications. If you look at 20 to 30% patients with epilepsy have the psychiatric disturbance. If you look at the intractable complex partial seizure, 70% may have one or more diagnoses consistent with DSM-R, and 58% have a history of depressive episode. There is a high risk of psychosis in patients with epilepsy, which is 6 to 12 times higher than the normal people. So these are some of the problems which has been more common with refractory epilepsy, but they can happen. These are the psychiatric conditions which can be associated with epilepsy. So major depressive disorder, 10.7% in normal control, but epilepsy patient is 17.4. Anxiety disorder are just double. Mood and anxiety disorder again is 1.5 times to 2. Suicidal ideation is completely more than 25% as compared to 13, and others again 22 compared to 35% in the patient with epilepsy. So how do we rehabilitate patients with epilepsy? It's a continuum that starts at a point of identifying the need. A point of rehabilitation may begin acutely after an identified injury, or may not be initiated until problems are identified in educational and or occupational. The goal of phase of rehabilitation are to focus on increasing strength, stamina, coordination, to facilitate mobility, independent in self-care, as well as issue of cognition and emotional functioning, which can help in recovery the maximum functioning. And the phase of rehabilitation may be quite extended with flexibility required to adapt to change that occur over time. The multidisciplinary team which we are talking for any rehabilitation is the part of team. And this is the model which I call it Maharashtra model of total epilepsy care, which I have developed in Maharashtra. And you could see that the blue color is the activity or responsibility of Epilepsy Foundation to provide the neurologist, pediatrician, EEG technician, therapist, speech therapist, occupational therapy, counselor, and social worker. We do the free EEG, TD, and CME workshop training. We do the street play, pamphlets, audiovisual, do's and don'ts, and we have an epilepsy mobile app which helps the patient to go wherever they want. And it also gives a reminder to the patient about the drug, etc. And these are the responsibility of government of Maharashtra to ensure infrastructure at district as well as sub-district hospital, specialization and medical officer to be present, school health worker, nurses, paramedics, pharmacists, lab technician, data entry operator, RBSK coordinator to be there, free blood tests, free CT MRI whenever they are available in that particular district hospital, free anti-epileptic drugs. So we are providing 3-month drugs, 9 drugs, including levetiracetam, to any patient coming in the camp on that particular day, and maintain record, spread awareness, coordination with MVT, local media, politician, telemetry. So wherever both color are mixed, these are the responsibility which we do jointly. So we are doing free epilepsy detection and management camp in the district area in rural of Maharashtra. We have an online epilepsy management system where the data are entered. We are doing the regular follow-ups. We are establishing regional epilepsy center in the 9 area in the Maharashtra, each about covering 500 kilometers, and we have free epilepsy surgery as part of the program. And you could see that what we have done in last 13 years, 12 years, more than 102 camps in Maharashtra, 34,000 plus patients of epilepsies are seen by the neurologists, more than 125 neurologists qualified from Maharashtra and outside Maharashtra. Free EEG for more than 4,600 patients, the counseling, physio, OT, speech therapists. Each camp there are 2 physio, 2 OT, 2 ST, 2 psychologists, and 1 cognitive therapist present. Hito is one of them who has attended more than 25, 30 camps. Free CT, MRI, and therapeutic drug para. So this is how we have been working for last 13 years. We have these performers which are filled by the individual therapists. So this is a neurological performance for physiotherapists. And we have some data which I present. There are various studies we did. We have about 15% seizure episodes which were evaluated. And then application of range of injury in this patient to overall population of patients with epilepsy has carried the risk of injury, the fall, the trauma which causes fractures. And children, particularly with cerebral palsy, have a higher incidence, high prevalence of epilepsy. And these are some of the papers which suggest that epilepsy and cerebral palsy has a correlation because of it not being development of the brain. So these are various studies. Sorry. And our study, we included about 2017, we did 6 camp and we included 156 patients where the motor milestone was delayed in 103, contracture were present in 59, and the patient who were independent were 54 and partly dependent were 42, dependent were 62. Muscle power was fair in 50 and poor in 35. So we also did this understanding the efficacy of group exercises. So we took we took this study. We did the children with epilepsy with comorbidity together. They gave it was 2 months they followed up. The criteria was 10 to 20, MMSE more than 18, comorbidity related to Barthel epilepsy and Barthel index of 17. And it shows that with a common comorbidity condition living together in a special school or center, they do better with therapy. And these are the exercises which was shown. And we found that these patients did better with even one supervised group therapy. And you could see that these are the children who has been given the group therapy there in the camp, and their trainer been taught what they should do regularly in the future. This is the OT format, which this OT has been seeing the patient, and we have another study which children with epilepsy and associated comorbidity with OT perspective, and they included motor, cognitive, and behavioral sector difficulties. And these are the exercises this is how they did evaluation, caregiver interviews, individual interview and treatment, group intervention, and community health worker intervention. So this is something we've done. And then these patients are even followed by telemedicine. So some of these patients who require long-term follow-up, we have done them through the telemedicine. And these are the comorbidity. If you could see in this patient, behavioral issue, GDP, ID, autism, ADHD, and the LD. And these are the ICF body structure and functional impairment, which will look into psychosocial, cognitive, and sensory motor, those which you can see. And this is activity participation limitation restriction, so play, work, school, and ADL. ADL was affected in 61% patient. And prior exposure to OT services, has they ever with this disability gone to OT? Some of them discontinued few times, 16%, once was 20%. Never was 53%. So epilepsy with disability in children are not even seen by the 50% patient are not even seen or treated. The reason was given was no time, no use, given up, unaware of services. So these are the challenges which you need to do. So we are provided, these are the intervention, and they has been worked very well. And this is the role of caregiver and community health worker is very important, and teaching them in the camp among the patient with disability was very, very important. And I think this is what we need to do, and there is a feasibility of OT services and sustainability of OT services can only happen if we take care of these people. And we also look into the caregivers and community health worker satisfaction. After the camp, they were highly satisfied, and you can see that both caregiver, community health worker, referral, follow-ups, everybody was so happy and part of the camp. This is a small video. I just show you that how difficult it is in the camps, because I travel 3 to 4 hours, sometimes 5 hours to reach to this area, see the whole day patient, we come back in the night, late night, after seeing 300 and 400 patients by our team of 45, 50 people traveling together. And these are some of the things which have been done in the camp. The therapists ask them, oh, you all know that what we are doing, what are the things which are doing. This is one of the, Nanded is the area where one of the biggest Gurudwara and Sikh temple is there, and we have seen about 4 or 5 camps. So this is a speech therapist performer, and we have Pune team which comes, and they have really seen 3,160 patients, and they saw about 4 out of these patients which we saw, 441 patient with speech and language problem, and these are the therapists which work there. And of the 441 children were 295, adolescent 89, and epilepsy were 298, and 143 were non-epileptic, and they did age-wise distribution among these. And these are the clinical observation what they found: no CP with epilepsy or Down syndrome, ASD, aphasia. These are the common problems which we see in the rural area, children with epilepsy. Again, we explored the group therapy in the speech therapy in epilepsy, and at the same Jawar camp, the therapist gave them some exercises for the tongue and talk to them. I'm also being there. I could see that what they are doing, so wanted to observe that. And it was quite a unique experience which we had with these children from various schools coming for the epilepsy camp by the RBSK worker bringing them to the camps. They are all line listed, and then the clinical psychologist, their performer is there, and she is also very busy. And we found that these are the psychiatric comorbidity, depression, anxiety, psychosis, intellectual disability, suicidal ideation, and pseudo-seizure is something which we have seen during the camp. And we also in the rural area found that substance abuse has been very, very common between alcohol, smoking, and tobacco. And treatment status also, we looked, poor compliance was 32%, on no anti-epileptic was 26%, only 42% patient of these who has psychological comorbidity are on regular treatment. So treatment therapy is very important, and again, controlled and uncontrolled. So 65% of patients who have this psychological problem are not controlled epilepsy. So that's something we need to do. So out of these 1876 patients, they saw their 866 adult, 770 were people with epilepsy, and these are the major psychiatric contribution, and these are the uncontrolled epilepsy in 600% patients. We also look at quality of COLI-10, and we had 238 patients where we did COLI-P for 3 months, and the patient has taken regular treatment at baseline at the end of 3 months. And you can see that once a patient is well controlled, his COLI-P changes with the control therapy. So that's very important. And you could see that quality of life once the treatment is seen at the end of the 3 months and 6 months, improve from the baseline. And we also look, our NGO, we look at the patients, their caregivers, and we organize personality development classes, and you would see that one of the patient is trying to put up the tie, they have never done. And this is the patient, this is our NGO picture, where they have been very actively involved. COVID came and we were shock-shelled, okay, what is to be done, patient is not getting the medicine, and how we are going to do. So I started online therapy. So every day there was something, and this is our epilepsy rehabilitation and management center. We could see that somebody is doing the sewing, another people are making the bags, they are very actively involved, and music therapy, and somebody training, yoga, and dance. So everything is being done on a everyday basis. We also promote some of this rangoli, making the bags, playing, children comes and play also, making the rakis. So all these activities been done at our place. So during the COVID, what we did is we did everything online. So music class Monday, OPD I continued on Tuesday, counseling on Wednesday, physio-OT on Thursday, cognitive therapy on Friday, and yoga therapy on Saturday. So patients were kept everything busy, and there are many patients who kept on regularly, and they learned the Zoom etiquette, keep their audio off, keep the video on while they are active. Other people, if they are not talking, video off. So even the children with disability learn how to do that. And we publish this paper, comprehensive epilepsy care during the lockdown, during the COVID-19 pandemic, in Epilepsy Foundation India model, and that is the model what we followed. So we are hoping to do no supervision, test screening for COVID, suspicious COVID screening, counseling of COVID patients, seizure related, change the epileptic drug, telephone follow-ups, no change, continue that. And then follow-up for cognitive therapy, psychosis, counseling, yoga, occupation, physio, OT, etc. So that's something which we follow. Last 2 slides, please. And this is the quality of life with the COVID pandemic, which we did the assessment, again online, and you could see that how it has changed. Concern point for patient with epilepsy was the emotion and the mental activities. So these are the challenges which we have now. One of the biggest challenge in providing rehabilitation services to unreached patients with disability living in rural area and small town with epilepsy. These are some of the recommendations which I recommended, and how we are following for this patient, for government, to how do we reach out to them, how we arrange the medicine for them, and how we can train the family. So we can change the life with little resources. Only thing is we need to have hidden devil to be identified, need for all concerned dealing with epilepsy to identify and intervene at early stage, comprehensive care of epilepsy management, need of the hour to improve the quality of life of people with epilepsy, need to understand that AED medicine or surgery alone may not give you 100% desired result. MDT need to work in tandem with each other, and education to patient, parents, society, and lawmaker is the key to success. We'll need more systemic data, though I have got now data of more than 30,000 patients and can shut out anything. And this is what this team, when we go for camp, you can see we go on the bus. And these are some of the activities we have done in the center. Thank you very much for your patience.